Okay, recording has started. It's so lovely to have you all back, guys. After a couple of weeks off from me, because I was on some funky shifts on A&E, but we have Dr. Bose with us, which feels very fitting, given Catherine was so instrumental in designing this series. It's our last one before Christmas, so everyone can chill, have a breather, have a rest before PSA at end of January. But thank you all for engaging with this series so much. We've got our final section session today on emergency drug dosing. And then after Christmas, a bit close to the exam, 3 weeks before, we're going to do a summary. So, an overview of everything we've covered with questions from different topics, different areas. Probably be a bit of a longer session just to really do like a whiz through crash course. And then we're also planning a timed mock for everybody as well. So, do come along to those in January. I'll be putting out the graphics sometime over the Christmas break. Maybe it'll be just for New Year, but it will be the first Thursday back and then the second Thursday back. And then we won't do anything week before. We might do like a Q&A before Manchester, sitting it on the 29th of January for those from other unis. But yeah, stay tuned and enjoy tonight's session. Thank you so much for being here.
Thanks, Charlotte. Okay, welcome everybody. So today we're going to be sort of reviewing emergency drug prescribing. So by no means is this every emergency drug. They're just key ones that I think I've come across during my time on F1 and from speaking to my colleagues. So hopefully it's helpful. Obviously, you don't need to know the dosing of these drugs off by heart, and I would always recommend looking it up. But I think having these at the forefront of your mind is very useful in practice, so that you can sort of act quickly and contribute to the team, but also very useful for your PSA because I think if you're going to learn any drugs, these would be the ones to know from that perspective as well. So there's just some key websites that you might want to get up on your laptop or whatever you're tuning in from. And a disclaimer that all of this content is made by F1s and F2s and it's for educational purposes. So always check your BNF and your NICE guidelines, which is what all of this should be based off of for every session. Okay, so the structure of this session is slightly different. For the whole session, we're just going to be doing prescribing practice because that lends itself to the topic. So you'll get lots of that in today. Charlotte will put a message on the chat and just like it when you're finished. But we're going to try and keep it nice and speedy and not have a super, super long session today. Perfect. So this is the first. Oh, I'm so sorry you guys saw the answer there. Charlotte, I need a small break.
Oh yeah, of course. Do you need to just do the slide
Yeah,
thingy?
I need to just take the answers off. I'm really sorry, guys. Very short break. I'll be right back. Um, the first question's quite easy for you, so I'd say do that in the meantime. But I'll literally be very, very quick and just sort that out.
Yeah, guys, just put your feet up. As you can tell, it's the last one before Christmas. And Catherine has also just started a new F1 rotation, so even with the busyness, we're all still here, so slaving in. But yeah, just two ticks. If anyone wants to grab a cup of tea, go for it. Somebody has, well, two people have just said in the chat about recordings and slides. So yeah, that's really odd. Recordings should be when you scroll up in the Teams chat. I don't unfortunately know how to disable the issue of not being at Manchester. If you filled in the feedback forms, what I will do for anybody from separate unis is I will probably give you access to all the different slides from the sessions you attended, and then um, recording links for the YouTube in that as well. And then you can distribute those as you wish to other people from your uni who have attended, because it is like a granted only access. And then someone from Manchester's just asked, yes, they've all been recorded. So you should literally be able to scroll up in the Teams chat and you can access every session we've done. The kind of give and take is like, if you've come to one, you've supported this group of doctors, you've given feedback, then it's fine for you to access all the recordings. But it's more people that have never been, that watch, don't give feedback, and just kind of use it. That's a bit of a pain. But yeah, that will all get sorted also over Christmas. It's just been a busy time, so I will get that sent out to you guys pronto. We'll get a team of us on it.
Thank you. Can you see my slides again?
We can indeed.
Fab. Okay, sorry about that, guys. I don't want to show you all the answers before you've had a go at trying the question. So let's start again. We've done all the intro stuff. So this is the first question. Please give it a go and try and work on that speed for the exam. Charlotte, do you want to pop a message on the chat for them to like?
Mm-hmm.
Yeah, okay, fab. Okay, so we've got a few people that have answered. So for timings, sorry, for timings wise, that's probably about 2 to 3 minutes that I gave you there, which is probably what I'd be aiming for. So if we just go through the questions. So you're called to a news call for a 43-year-old female on the gastro ward with severe lower abdominal pain. They describe it as sharp stabbing and it's been increasing for 10 days. She was admitted 1 month prior with an upper GI bleed. So in their past medical history, we've got cirrhosis, laparoscopic cholecystectomy, hypertension, high cholesterol, and Gilbert syndrome. She's not got any drug allergies and she weighs 48 kilograms. So we've been asked to prescribe analgesia. So the answers here, you can have multiple answers here, so don't worry if you've not got something that's on this slide. But a good starting point would be paracetamol. So you can give that oral or IV. In her case, if it's very, very severe, you might just want to give it IV if she has access, but oral is a fine option. You guys might notice that the oral dose I've got here is a little bit lower than you might be familiar with or you might want to prescribe. And I've put that because she has a background of liver cirrhosis, and we want to just be cautious with our use of paracetamol in people with existing liver disease. So in terms of the PSA, I wouldn't say that you get marked down for putting the paracetamol dose as a maximum of 4 grams per day. So that's your usual dose. But in practice, you might want to be aware of this. Sorry. And the IV dose, so there's dosing guidelines on the BNF page about how to calculate your IV dose, and that'll be based on weight. So that's why I've got a very specific number here. And one thing to highlight to you guys is that you need to be careful with your dosing of paracetamol if someone's under 50 kilograms. So that's why in this question, this patient has a weight of 48 kilograms, and it's just to get you to be able to spot that. Okay. I've also got tramadol as an option here as a slightly stronger pain medication. So with that, you give a stat dose first. So if this were your PSA question, you wanted to prescribe tramadol, you would just prescribe the stat dose. And then, later on, if this were real life, you'd prescribe the maintenance dose. And then we've also got morphine sulfate, which is a very good option when someone's in pain. And that can be given as 5 milligrams IV every 4 hours. There is also an alternative oral dose, but in this situation, it's a news call. She's in severe pain, so IV would be fine if you have access. So I've just highlighted at the bottom here your usual dose of paracetamol. It's such a key one to know. And also that there's a reason I haven't prescribed any NSAIDs in this patient. It's because they've come in with a history of an upper GI bleed. So I think that one's less appropriate, even though that is one of your first line medications for pain. Okay, does that all make sense? No questions, fab. So here I've just got the WHO analgesic ladder, which I'm sure you're very familiar with, just to remind you of the steps. Paracetamol first, NSAIDs, never use 2 NSAIDs together, your weak opioids and your strong opioids, and then your specialist techniques. And by the time you get to persistent pain, even on strong opioids for your patients, most hospitals have like a specialist pain team. That's practically what you'd want to be, who you'd want to be getting involved in the patient's care next year when you're in F1. If you're prescribing opiates to anyone, not so much in the emergency setting, although I probably still would do it, but always be aware of prescribing a laxative with it. And especially if they've never had opioids before, then an antiemetic as well, because it can make people very sick and it can make them constipated quite quickly. Fab. Okay, so just summarizing pain, key drug to know, morphine, like we've discussed. So you can give 5 milligram orally every 4 hours, and you can give up to 10 IV every 4 hours. But I would definitely half the dose in someone who's elderly, or if someone's particularly sort of like physiologically frail. It's just be more appropriate to give a much smaller dose. And into someone who's opioid naive, then 2.5 milligrams could be an appropriate starting dose as well. So practical tips for F1, consider if the patient's opioid naive or not. Consider that PRN, antiemetic and laxative, and always have in mind your WHO analgesic ladder to see what the patient's tried so far. Okay. So this is the next question. Give it a go. And I'll let you know at about 3 minutes.
Sorry, I realised I didn't put a thingy in the chat, guys.
It's fine.
I do have a brain, I promise. It's just mentally listening to Jingle Bells. Um, that's where she's at. But yeah, we've already got 4-5.
That's fine. Guys, just a quick interruption. There's a slight mistake on the slides, just to highlight that and be super honest about it. So this first dose of morphine, 5 milligrams IV, is what I'd go for. I wouldn't go for 10. It's too high. So that's just a typo there. I'm sorry about that, guys. But yeah, the first one's correct. Okay, how are we getting on with this question? 6, fab. Okay, let's go through the answer. So here I've put clopidogrel and aspirin. So aspirin is a given, and I feel like you guys will be quite confident with that. Clopidogrel is your second antiplatelet. If you've put something else like prasugrel or ticagrelor, that's fine as well. This is just the one I chose. So with your anticoagulants, often you have your stat dose, which can be higher. And depending on some trust protocols, it might not be 300 milligrams, it might be a bit higher than that. And then you're followed by your regular maintenance dose. The minimum time tends to be about 4 weeks, but patients can be on this for a year or longer after their STEMI. And then your aspirin, 300 milligrams stat dose, you guys should all be familiar with, and that needs to be chewed or dispersed in water. So if you had a counselling question on how the patient needs to take the medication, that might be something that they could ask. Okay. We've not got any questions in the chat, so let's keep going. Fab. Okay, so just key sort of information. So initial treatment in a MI. So the mnemonic Mona is probably very familiar to you guys. So morphine, I'd start with 5 milligrams, more appropriate, with your antiemetic as well. Oxygen only if they're desaturating. So you don't need to give oxygen if their saturations are normal. That can be harmful to the myocardial muscle. Then your nitrate, so you can give your GTN spray and be careful with that prescription. It's in micrograms, not milligrams. And you can repeat those sprays 3 times. And then you've got your aspirin that we've talked about. And I've also put the other antiplatelets that you might want to give. So it's really, in real life, you base it on the trust guidelines, but in terms of the PSA, as long as you're aware of these and have those to hand, that's absolutely fine. And then my practical tips for this would be just be a little bit cautious of the nitrates, because they can lower people's blood pressure, especially if you have an older, frail patient. As we've said, half the dose of morphine for elderly, frail patients. And you guys should be familiar that the symptom onset should be within 12 hours for PCI. And you want that access to that procedure, that PCI procedure, to be within 90 to 120 minutes. So those should be sort of key timeframes that you have in the back of your mind. Okay, let's move on. So another prescribing practice here, just like Charlotte's message when you've given it a go. I've just seen a question in the chat regarding morphine. So what's the definition of elderly? It's a really good question. And in terms of your PSA, so I think it should be obvious in the question whether the patient's frail. So they might give you a frailty score, like the Rockwood frailty score. They might give you a very poor renal function, so you've got an EGFR of say 30, or a history of chronic kidney disease, multiple comorbidities, a particularly low weight. Those would all be the things I'd be looking out in the question stem. And I'd probably give a reduced dose in the PSA in that scenario. But in real life practice, I would say the majority of your patients probably could be classed as frail. Those tend to be the people that make it into hospital. So once again, multiple comorbidities, poor renal function, low weight, very low sort of BMI. Those are the types of things I'd be thinking, maybe a reduced dose would be more appropriate. because these doses are for the average weight usually. Hope that answers your question a little bit and it's not clear cut off. Okay, we've got lots of responses to this question. Okay, let's go through it. So we've got 34-year-old lady. So she's got urticaria, wheeze, facial swelling, and hypotension. So she's just received an IV antibiotic on the ward. She's breathless, she's hypotensive, and the MET team is called. So that's the medical emergency team for people who aren't familiar. So we know that she weighs 70 kilograms, no significant respiratory or cardiovascular history, and please write a prescription. So we're thinking anaphylaxis in this patient. Key things to look for in anaphylaxis is heart or sort of blood pressure compromise, because I think that's something that can be forgotten, but hypertension is a really key sign. And then obviously your wheeze, breathlessness, tongue swelling, all of that. So the answer here is 500 micrograms of intramuscular adrenaline stat. And the key thing that could slip you up here is the concentration. So for anaphylaxis, we've got 1 in 1,000 adrenaline versus your cardiac arrest, which would be 1 in 10,000. So that's something to look out for. I think easy things here would be to accidentally not put IM and you could put IV in the stress of the exam. So that's key, and that it's micrograms, not milligrams. Perfect. And this is an adult, so that's just your standard adult dose. And just some information about anaphylaxis. So those are your doses. I would probably learn those. I think they're quite relatively easy cut-off points, and I like to know the milliliters that you give as well. That makes a bit more sense to me. You can repeat this dose every 5 minutes until you get sort of like critical care support. And it's given in the anterolateral aspect of the middle third of the thigh. So practical tips in anaphylaxis. So stop the offending drug if that's what's caused the anaphylaxis. I think that would be quite easy to forget and just jump in. So stop the drug. You can lay the patient flat or put their legs in the air, and that can help with their hypotension. Give high flow oxygen as soon as possible. You can give a crystalloid fluid bolus. And if your life-threatening features are still there, you can keep giving that adrenaline every 5 minutes until you get your specialist support. And those would be key things for next year for you guys. Okay, just check the chat for any questions. Yeah, sorry, why are you raising their legs in the air? So that can really just help with their hypertension because they're systemically unwell. And yeah, that's in the guidelines. So yeah, and just lying flat really helps as well. Perfect. Good question. Okay, so have a go at this question as well and like the message in the chat when you're done. And keep up that speed. I think you guys are doing really well.
Also, just general thing on the anaphylaxis, guys, you have the main priority is keeping the patient flat and not letting them get up because you don't want them to be moving around. Like if they need to be seated because it helps their breathing, you can have them do that. But main thing is keeping them still flat, like getting adrenaline as soon as possible. And then later on down the line, you can give further doses, but keeping them monitored for like refractory anaphylaxis and stuff. There's really good guidelines on it from Resource Council, but just don't let them get up and move about. So at really high risk of like profound hypertension and then collapse.
Yeah. Oh no, no one's liked it yet. Don't worry guys, take your time. Okay, we've got lots of likes. That's fab. Thanks guys. Okay, so we've got quite a young man here. He's breathless. We know he has a history of asthma and he's speaking in very short sentences. So he's tachypneic, he's tachycardic, his SATs are low despite 15 litres of oxygen, and his peak flow is really quite reduced, so it's less than that 33%. And he's already received some salbutamol through a spacer, but that's not had too much effect yet. So it looks like he's got a severe acute asthma, but it's not life-threatening. Do you guys know one of the parameters that we would look at to see if it's life-threatening or near fatal? If anyone could answer that on the chat, that would be great. So we're going to prescribe him some initial nebulizers. So the answers here are salbutamol and ipratropium nebs. You might hear ipratropium being called Atrovent, and essentially these two together can sometimes be called combi nebs as well. So people call them different things, but they're to help with your wheeze and open up the airways. So salbutamol, you can give 2.5 to 5 milligrams, and then all of these medications, you want them immediately. So you want to be prescribing them as a stat, and then you can repeat them within the time limit of the BNF. So the BNF says that you can repeat that every 20 to 30 minutes as needed, and the nebulizer can be driven with oxygen. So that's quite key because you can have nebulizers driven with air as well. And in this case, they're hypoxic, so give them the oxygen through the neb as well. And you've got ipratropium bromide as well, so that's in micrograms, and that one's repeated a little less often. So yeah, those would be your two good drugs to be aware of. And it's important to monitor the potassium levels of a patient if they are using regular nebs. So as you guys might be aware, salbutamol can be used in the treatment of hyperkalemia to lower your potassium. So you just want to keep an eye that the potassium doesn't become too low if someone's using these frequently. So I hope that makes sense. I'll just check the chat. Yeah, so you guys have all got great answers here for near fatal and life-threatening asthma. So for life-threatening, you'd want to be looking at your CO2 on your blood gas, and your CO2 would be normal. Now, in this situation, that would be abnormal because you want your asthmatic to be breathing quite quickly and blowing off CO2. So if it's getting within that normal range, it shows that they're becoming tired. And that's a worrying sign. And then in near fatal asthma, they're so tired that their CO2 starts to rise above the usual limit. So really good knowledge, guys. Let's keep going. Okay, more on asthma. Right, so your initial treatment, so high flow oxygen to maintain their target SATs. We've talked about salbutamol and ipratropium. You're also going to give prednisolone or hydrocortisone. So you want to be giving a steroid. There's no added benefit of giving it IV. Oral's absolutely fine. And the dose is 40 to 50 milligrams. And the course is usually 5 days as a minimum, but sometimes people do have longer. And then you can consider whether magnesium sulfate is required. So the dose of that's often 2 grams IV, and it's given over 20 minutes, or aminophylline as well. And those last two would be sort of more of a senior-led decision. Personally, as an F1, I wouldn't be starting those by myself unless I had senior support. And with aminophylline, you need to monitor that with levels as well. So that's another consideration for you. But initially, just be comfortable with your oxygen, your nebs, your prednisolone, and antibiotic cover if it's an infective exacerbation of asthma as well. Practical tips for asthma. So call for help early because they can deteriorate really quite quickly. With these patients, with every patient, but I think with these patients, be aware of their ceiling of care. So are they just for ward-based care? Do they have some treatment escalation plan already in place? Or are they for full escalation? Are they someone that's previously been on ITU and done very well? And so they'd be for ITU again. So just having an awareness of that. Ensure your nebulizer is driven by oxygen. We've talked about that, and that's only if the patient's desaturating. Peak flow monitoring is incredibly helpful, and knowing the patient's baseline peak flow when they come in. And then an ABG is really useful for monitoring that CO2 in particular and seeing whether you have type 1 or type 2 respiratory failure. Perfect. So I'll just check the chart for any questions. Nope, done. Let's keep going. And just like the message in the chat when you're done. Okay, great. Let's go through it. So you guys should be aware that this is status epilepticus. So the answer would be one of your benzodiazepines. So if they've got IV access, then IV lorazepam, 4 milligrams. If they haven't, then you can consider PR diazepam, and that's 10 to 20 milligrams, or oromucosal midazolam, which I think is often given to people who have epilepsy to take home and maybe use in the community. I think with anything sort of oral in a seizure, I would just be a little bit cautious in case the patient is biting their tongue, and that might be difficult to administer and not too safe for whoever's administering it as well. So I think if you have access, IV is probably easiest. But those are your options and that's the first line treatment. Okay, I'll just check the chat. And then just some high yield information on status. So it's a seizure lasting 5 minutes or more, or it's recurrent seizures without recovery in between your seizures. And this can include febrile seizures as well. Just a little tip, an oropharyngeal airway might be less appropriate, like we've talked about in a patient who's seizing if they bite down on it. I know they are quite tough and it wouldn't necessarily occlude the airway, but I think that's probably a bit less appropriate. So your first line is your benzodiazepine, like we've talked about, and that can be repeated once after 5 to 10 minutes if there's no improvement or it doesn't terminate the seizure. And then if you've given 2 doses of benzos, then you can give an anti-epileptic, and there are some different options. I think Keppra can be quite common, or phenytoin. And if there's still no improvement after that, then you'd be thinking about anesthetic support for a rapid sequence induction, so general anesthesia. And you guys won't need to know this for PSA, but I think there are some anesthetic agents that are more commonly used for that because of anti-epileptic properties. Well, so I hope that makes sense. And just being aware of that first line medication that you might want to give while you're waiting for more senior help to arrive. Okay, just check the chat, nothing in there. Let's move on. So have a go at this one and like the message when you're done. Okay, let's go through it. I think the speed on that question was great. Fine. So the answer is adrenaline and amiodarone. So we've been given in the question that this patient's cardiac arrest is in a shockable rhythm. So we know that adrenaline and amiodarone are appropriate, and we can give these drugs because we've also told in the question that it's after the third shock. So in a shockable rhythm, you give these drugs after the third shock. And we've talked about adrenaline dosing previously. So for cardiac arrest, it's the 1 in 10,000 dose. You give 1 milligram stat. And then for amiodarone, it's 300 milligrams. And those are just really good ones to know. So well done, everyone. So just quick, really high yield things about advanced life support. So you've got your non-shockable and your shockable rhythm pathways. So in the non-shockable rhythm, the only drug you're really going to be giving is the adrenaline, and you can start that as soon as you have IV access. And once you do give it, you can give it every other cycle, which is roughly every 3 to 5 minutes. So adrenaline's the only one, or it's the primary one, and then you give as soon as possible. Then for the shockable, like we've talked about, you have adrenaline and amiodarone, and you give those after the third shock has been delivered. And the amiodarone can be repeated at a lower dose after the fifth shock as well. So you guys should be aware that your non-shockable rhythms are your pulseless electrical activity and asystole, and that your shockable rhythms are VF and pulseless VT. Just be aware that the intraosseous route is an alternative route if you've not been able to get IV access, and that the tibia is a common location for that to be given in these scenarios. Okay. So have a go at this question. I know there's a bit more writing here, and just like the message when you're done. Okay, let's go through it. Fine. So you're asked to see a patient by the nursing team with concerns over drowsiness. So you arrive and they're not responsive, and you can see that they're 2 days post-op from a laparoscopic cholecystectomy. So your airway, they're making a snoring sound, but you pop in an oropharyngeal and they tolerate that quite well. Immediately, because you're putting in an airway adjunct, as an F1, would be calling for help. So you put out 2222 to get some more senior support. While they're on the way, you can see that they've got a low respiratory rate and they're desaturating, but they've got equal air entry bilaterally. So you ask the nurse to bag valve mask them with 15 litres oxygen attached, and you also ask the nurses to get an ABG. So then their blood pressure, they're slightly hypotensive, but they're not tachycardic. They're well perfused. Their heart sounds are normal. And let's say they've already got a cannula in, but you maybe ask for another cannula as well. Okay, their blood glucose is 5.1, so unlikely to be a hypo. And they're apyrexial. They're unresponsive, and their pupils are 2 millimeters, which is quite small, and they're poorly reactive to light. Their calves are soft, they've not got edema, no rashes or bleeding, and you can see they've had patient-controlled analgesia on the drug chart. When you check everywhere else, they've also got an opioid patch on their left shoulder. So I've asked you guys to prescribe some treatment. So the treatment will be naloxone. So it looks like this patient's had an opioid overdose. There are two naloxone regimens in the BNF. So there's the high dose regimen, which is to be used if you're immediately concerned and you think that this might be life threatening. And then there's the low dose regimen, which is when you're worried that by giving the naloxone, it would have an undesirable effect. So obviously it's helpful, but say if the patient is a chronic opioid user for poorly controlled pain, or they're a post-op patient who, like this patient, who's accidentally had too much analgesia, but you don't want all that analgesia to wear off at once and then they're in heaps of pain, or they're a palliative patient as well. So you obviously want your palliative patients to stay comfortable towards the end of their life. So there are two regimens. And the high dose regimen, 400 micrograms, is the first dose, whereas the low dose regimen, you've got 100 to 200 micrograms. So whatever's more appropriate, be guided by what will happen after you give the medication. And in terms of high yield stuff for opioid overdose, so you give the naloxone if there's that reduced consciousness or slowed breathing. So this patient doesn't have an adequate respiratory rate, they're needing the bag valve mask. So they obviously need their naloxone. You really want to monitor the patient closely after you've given it because the action of the naloxone is shorter than the action of many opioids. So you give the naloxone, but it wears off quite quickly, and then the symptoms return and their resp rate might fall again. So you might have to give repeated doses of naloxone. And there's some sort of more unusual opioids that I've not come across yet, but the BNF does mention to just be aware of that have very long durations of action. And your naloxone can be given as a continuous IV infusion if it's required for an extended period of time. So in terms of spotting your overdose, hopefully you saw in the question that they had reduced consciousness, had those pinpoint pupils, so we class that as being less than 2 millimeters, and your respiratory depression, so that's less than 12 breaths per minute, that shortness of breath, any signs of cyanosis as well. In this situation, really important to check the blood glucose, so not to forget that, which we looked at, and to check the patient for any other ways that opioids might be getting into their system. So review the drug chart, review whether it's paper, online, check that they match, and look for any syringe drivers, any opioid patches that the patient could be using. Okay, and that's a little overview of opioid overdose. So have a go at this next question. I'll just check the chat. No, there are no questions, so just keep going and like the message when you're done. Okay, I don't think anyone's liked the message yet. Are you guys struggling with this one a little bit more, maybe? I think we will just go through it because you guys might be overthinking it a little bit. Yeah, struggling. That's fine. That's fine. Don't worry. It's not. This is more of a like a practical tip question. So we've got a 63-year-old man. So he's got large volume hematemesis and he's feeling very dizzy. He's tachycardic. He's hypotensive. His respiratory rate is a little on the high side. His fats are sort of acceptable, and his initial bloods show that his HB is 68, which is pretty low, and his platelets are quite low as well. So the surgical and gastro teams are on their way, but you've been asked to prescribe the immediate blood products. So here the key thing is the hemoglobin. So if your hemoglobin is less than 70, that's a transfusion threshold. So you want to be giving blood. And if it's less than 80, but the patient also has a history of cardiac disease, then that's also a transfusion threshold. So we've not been given that information here, but it is less than 70. So that's enough, that's low enough to transfuse. So the answer here is 2 units of packed red cells, stat, because it's urgent. I know that's sort of like difficult to look up in the BNF, but this is more of something you should probably just try to be aware of. So the way that you do this practically as an F1 is you would activate the major hemorrhage protocol in your hospital. So for some hospitals, that might be the same line that you call to activate like a news call or a medical emergency call. But for some hospitals, it's a little bit different. So when you guys do get to your shadowing weeks, that's one of the key questions kind of ask, how does your hemorrhage protocol work? And what they'll do is they'll release a porter and they will stick with you throughout the whole emergency. So that's your porter. And they will go and collect the blood, bring it to you. And if more blood's needed, they will go and collect that blood as well. I hope that makes sense. Sometimes blood prescriptions are on paper forms, so just be aware of that. And if the patient hasn't had a group and save or a cross match, that's obviously you need to try and get one of those. Also, a VBG is really good for hemoglobin monitoring, and you also can send some formal bloods as well, if that's possible, to just to check them against each other. So the answer is 2 units packed red cells, and that would be through your emergency blood, so it doesn't need to be matched to the patient. So just some high yield information about upper GI bleed. These are just things I would be aware of. They're not in a specific order to do that step by step, but you're really wanting IV access, ideally 2, and a larger cannula as well. You want to think of immediate fluid resuscitation. So while you're waiting for that blood to arrive, you can give fluid. And you want to then be replacing the blood you've lost with the blood products. You can consider terlipressin to reduce the bleeding in variceal bleeding. So if this patient, say, in their past medical history, if it had known varices relating to alcoholic liver disease, then that could be prescribed. And then especially for variceal bleeding, you want to give antibiotic cover for SBP. And one of the key things which I have learned is that in this situation, you might think you want to call the on-call gastroenterologist. It's actually the endoscopist that you need, because they'll need an urgent endoscopy, and that's actually a separate person sometimes. And you can calculate a Glasgow Blatchford score for the patient prior to endoscopy. And you really want to be reviewing their meds. So it's important to know, has the patient had any NSAIDs? Are they on anticoagulation? And then you can consider reversal. It's less likely that they'd be on warfarin nowadays, but what if you could give some vitamin K? And then after endoscopy, you can consider an IV proton pump inhibitor. And that's helpful because it prevents rebleeding after the endoscopy. So those are just things that would be floating around in my head, probably quite stressed head, while you're waiting for help to arrive, and how you can contribute as an F1. So practical tips when you're prescribing blood is thinking, are they at risk of fluid overload? So for patients who are at high risk of fluid overload, but they do need a transfusion or they need fluids, then you can consider writing up a stat dose of furosemide to be given with the blood to help them not become overloaded. And then do they require irradiated blood? So this would be possibly cancer patients or patients on immunotherapy, or if a patient's had a previous organ transplant as well. So that's a special type of blood to reduce the risk of the graft disease, and that's should be on the blood form to consider that for the patient. And then it might seem quite simple, but what's the cause and how can you address the cause? Because if you're giving blood but they continue to bleed, that's not going to get you all that far. So hopefully that's a little bit helpful and a bit different. I'll just check the chat. I've not got any questions. What's the relevance of the INR? So let me just get the INR reference range up for us. Because they are different. So INR reference range is 0.8 to 1.2, so that's normal, so that's not too relevant in this case. But it's good to have the INR on your radar, especially if the patient is on warfarin, for example, and their INR is, say, 10, it's really high, then you want to consider giving vitamin K or PCC to reduce that. And there are quite good guidelines for that on the BNF. That would actually be a really good thing to put in future sessions. I will remember that for you guys' mock. So really good question. There's a good page on that in the BNF, actually. That's a very testable PSA thing. Okay, let's keep moving. So this is taken from Almost a Doctor. I really like that website. And it just gives you considerations for managements of GI bleeds. So just 3 common causes here, and when endoscopy might be appropriate, and whether you treat with like banding or for surgery. So just for you guys to have an awareness of the different causes, I would say. Perfect. So have a go at this question and like the message when you're done. We are getting through this. I know that we're coming up to an hour, but we're really quite close to the end. Okay, great. We've already got lots of answers. So you're asked to see this patient. They've got very low blood glucose. I would be a little bit worried. You put out a news call because that's not good. So they've got snoring sounds, corrects with a head tilt chin lift, but you can't do that forever. So you'd want to get an airway adjunct in. Their respiratory rate and SATs are fine. They've got good air entry. Their blood pressure is a little high, but it's fine. The heart rate's fine, well perfused, and they've got IV access in place, which is great. Got very low BM. They're not pyrexial. Pupils are equal and responsive, and they do respond to pain when you do supraorbital pinch. Not got edema, calves soft, non-tender, nil rashes. And you've looked at their medication chart, and there's no sort of acute medication that you think might have caused an overdose. So please prescribe an appropriate treatment. So here I've gone for IV glucose because they have the cannula in place already and they are so unresponsive that they wouldn't be able to take oral glucose. So you can give, there are two strengths that you can give. So you just give a little bit more in volume of the 10%, which is a lower strength, and you give a little bit less of the 20%. So either dose is fine, and that's what's in the BNF. Perfect. So quickly on hypoglycemia. So you've got your sort of like three methods. So you've either got giving oral glucose, and that is preferred if their blood glucose is just a little bit low and they might be feeling sweaty, tachycardic, a bit dopey, then give that. You can also give glucagon IM or the IV glucose like we've talked about. With the only consideration is that you can only use glucagon once. So that releases glucose from your liver stores. And that IM injections are just more painful for patients. So possibly just consider that when you're prescribing. Might be less appropriate as well if the patient's particularly malnourished, because they might not actually have too much in stores to release. And you need to use the IV route if you've got prolonged hypoglycemia or it doesn't respond to your glucagon after 10 minutes. So say if you were to try your glucagon and there's no improvement, then you need to get IV access and give some IV glucose. So just check the chat. Fab. Okay, let's keep moving on. So give this one a go. So I've kind of told you what it is here. We've got the opposite problem for a 23-year-old man with type 1 diabetes. Just quickly, if anyone does need to leave because the time is getting on a little bit, then please just remember to fill out the feedback form. It should be at the top of the chat, but I'm sure Charlotte could just pop it in again so it's a bit easier to find. And then we'll know what's useful for next time.
Yeah, sorry, it wasn't sending just then. I had to click somewhere else, but it's just there, guys.
That's okay. I appreciate it's nearly dinner time, and it's been a long day for everyone. Okay, so we've got one like. That's great. Should we go oh, we've got a heart. That's nice. Should we go through this one? Because people might be struggling a bit. Okay. So we've got someone with a very high glucose and they've got high ketones as well, and they are acidotic and their bicarb is low. So they've got a metabolic acidosis. And we know that they weigh 90 kilograms. We've already prescribed some IV fluids, so that's good. But what's next? So it's a fixed rate insulin infusion, and we're going to give Act Rapid 9 units per hour, made up to 50 mils with 0.9% sodium chloride. So how did I get 9 units? So I use 0.1 times the patient's weight per hour. So 0.1 times 90 kilograms per hour, and that's how we got the dose. And we're going to continue that until the ketones and the pH normalizes, because that's what we're worried about. Key thing to be aware of is if the glucose level falls below 14, you don't need to reduce the insulin rate or stop it. if the ketones and the pH still abnormal. So that's what we're trying to reduce. So you keep going with the insulin, but you obviously don't want them to become hypoglycemic. So you add some 10% dextrose to prevent them becoming hypoglycemic. So I hope that makes sense. And just high yield info. So you're going to give your 0.9% sodium chloride IV, so your fluids first, then your fixed rate insulin infusion, and that's a really good dose to learn. Obviously, check your hospital protocol policy, but 0.1 units per kilogram per hour. And you continue the patient's long-acting insulin. That's quite important. So you stop their short-acting insulin, but you continue, say if they're on Lantus or something like that, you continue that. Useful investigations, ECG, because we're worried about electrolyte disturbance, VBG, very quick, helpful for our pH, and bicarb and all of that. UNEs, once again, blood cultures, you might be thinking, well, what's set them off to go into DKA? A chest x-ray and a MSU to be sent as well. Or also thinking about triggers, could an infection be causing this? And then you have a very close monitoring regime in practice, so that would be on your guidelines, but usually hourly BMs and ketones. And then you also want to keep a close eye on the bicarbonate and the potassium, because as we've sort of talked, I'm not sure we talked about it actually, but insulin can impact your potassium. And consider the precipitating cause and treat those. So your diagnostic criteria for DKA, so you want all three to be present, and it's your blood glucose over 11 millimoles per litre, your capillary ketones over 3, or your urinary ketones being 2 plus positive, and your venous pH being less than 7.3. So I think 3 is kind of a key number to remember here. Plus or minus also having a low bicarbonate under 15. And if you can't get IV access early, then request critical care support. So some hospitals have people that specialize in gaining IV access. That'd be really important here. And a GCS is very useful as well, as to include that in part of your ATE assessment. So let's keep going. So have a go at this one, guys. I believe this is the last question, if I do remember. So almost at the end. Sorry, we've got some questions on the last question. So how do you know how much sodium chloride to add with the insulin? So that is what it says in the BNF. So it says mix with 50 mils of sodium chloride. So that seems quite set. But once again, you check your hospital policy, but for prescribing assessment, that's what the BNF says. And if they were 94 kilograms, would you round or give 9.4? I would probably give either. I think I would speak to practically. For a PSA, I would just write the exact number that you've calculated. But practically on the ward, I would go to the nurse and I'd say, is this difficult to give to the patient? Is it easier like this? And that would guide me. I know that's not a super clear answer, but that is what I do, because nurses are really good at knowing how they actually give the medications and what is quickest and easiest. I'll just put message on the chat for you guys to like when you've had a go at this last question here. Okay, wow, we got lots of answers already. That's great. Well done, guys. So the answer here is enoxaparin. So we think this lady has an acute pulmonary embolism. She's desaturating really quite a bit. She's starting to drop her blood pressure. And we know that her EGFR is 95, which is important when you're prescribing enoxaparin. And we know that her weight is 75 kilograms. So we've got enoxaparin sodium, 75 milligrams, subcutaneous BD. So that is according to the BNF dose for a symptomatic pulmonary embolism. So that's how I found the guidance for this. So if you just type in enoxaparin sodium, and you'll see the different indications, and I went for the symptomatic one. In terms of practically, so that's what would be my answer for the PSA. But on the wards, there's usually a hospital policy on treating DVT and PE, and there'll be a specific low molecular weight heparin and specific dosing regime, so either once daily or twice daily, that you would want to be looking at. But key things to note is that the prescription's by weight, and that you want to check the renal function as well. So that would probably be all I would say for that one. So you start the enoxaparin practically how it works is you start the enoxaparin, and then you would maybe convert them, or you'd likely convert them to a DOAC at a later date. But the enoxaparin is quite good because you can reverse that quite easily. It's more difficult to reverse the NOACs. So that's what you start them on. And you guys should be aware that if you've got a provoked DVT or PE, you give anticoagulation for 3 months, and if it's unprovoked, it's 6 months, possibly lifelong, depending on any further workup that the patient will have. You should be aware of all their baseline renal, liver, blood function, including the clotting as well before you prescribe this. If not, send those bloods off as you're dealing with this. And what's key about this question is I put that imaging is arranged, but it'll be at least 45 minutes. That's really quite quick, I would say, from my experience. So that's in there to say that you don't want to wait for the imaging results before you start the treatment dose, because you can always stop the treatment dose very easily if the imaging were to come back negative. So that's why it's appropriate to prescribe. And you have to seek specialist guidance in renal impairment. And another just like last little bit for you guys to take away is with low molecular weight heparin, and also with DOACs, the dosing can be a little bit different if someone's at an extreme of body weight, so especially particularly obese patients. So there was a patient recently that I saw who was on regular factor 10A monitoring for their apixaban, because they were sort of well over 100 kilograms. So there are some extra considerations depending on the weight there. Just think while I was explaining that could be a good monitoring or sort of data interpretation question for the PSA, actually. So it might be worth just thinking about factor 10A levels and NOACs or DOACs if you're interested. So that was the last question. There's literally just this one last slide, more for your information about hyperkalemia. The protocols for this, I do imagine, quite specific to the hospitals, but just a summary for you. So you want to be intervening if it's over 5.5, and if there are ECG changes, that's more of an emergency. It requires urgent treatment. And if the level is over 6.5, that's severe. So you want to be giving a calcium gluconate or chloride, 10%, so that's to protect the cardiac membrane. You want to be giving IV insulin or dextrose, and that's to shift the potassium into the cells. And then, like we've talked about, you give salbutamol nebs, so they lower the potassium. So that's a good thing in hyperkalemia, but it can be a bad thing if you use too many nebs in asthma or COPD. And then you can also consider a potassium binder or a loop diuretic in the more long-term management. But it's really important to get that ECG and to also consider the rate that the potassium increased. So if someone's had a climbing potassium ever so slightly over a longer period of time, and it's just popped into that, say 5.6, I would be less concerned with someone that's presenting as quite unwell. They had a potassium of 3.5 and it's suddenly 6.2. So that more rapid increase would be more concerning. Always review the drug charts. If there aren't any medications that might cause hyperkalemia as a side effect, suspend those. And there are some special considerations in those with chronic kidney disease. So sometimes sodium bicarbonate can be recommended. That would definitely be something to discuss with your SHO. So that was just a little overview for your revision. And that's everything for today. So thank you so much for coming and being so speedy and practicing to time. If you could fill out the feedback form, I think it's also in the chat, then that would just help us guide the future sessions a bit better. And I'm happy to answer any questions. Oh, there are some questions on the chat. Fine. No, so you would, the way it works in my hospital is you give enoxaparin while you're waiting for the PE to be confirmed, and you then switch to a DOAC, but you don't have to do that. That's not, you can start a DOAC, that's fine. Say if you had, say, a DVT that was confirmed on Doppler, you can start a DOAC. That's all right.
Yeah, any issue with slides, anything, if you could just email manchestermeded@gmail.com, we can take care of it from there. Just helps because the whole team can see it that way. But thank you everyone for coming.